All right. Again, hello everyone for joining the MedSurg 1 tutoring session today. Uh, so today we are going to cover the respiratory nursing care. Okay. So respiratory nursing care in this topic, especially MedSurg 1, we will go over a lot of different patho and diseases relating to respiration, especially mostly is the lower lobe. So that's why we're going to focus primarily on the lower lobe of the lungs. And again, this is the attendance QR code. If you guys watching on YouTube again or later, please also scan and put your sign in so that we have the number of the people who join or actually watch the sessions. All right, let's go ahead and get started. So like I said, we really need to focus on the lower respiratory tract. So we need to know what includes in the lower respiratory tract. So the lower respiratory tract include bronchi, the bronchioles, the alveolar duct, and the alveoli. So the most important thing that I think you guys should know is the bronchioles and the alveoli. The alveoli is what allow the gas exchange. It allow oxygen in and transport the carbon dioxide out. It's this like tiny little sac that's in our lungs. So if the airway collapsed, it means that also known as atelectasis, this is relating to the alveoli. The alveoli isn't expanding enough so that the air can get in. It's collapsed. So whenever we heard the terms atelectasis, it means the airway is collapsed. It means the alveoli is collapsed. It cannot expand and get lungs and get the oxygen in. So for the lung lobes, we have 3 lobes for the right lung and 2 lobes for the left lung. So this is just anatomy. Okay, so it's important to remember that on the right lungs, we have 3 lobes, and on the left lung, we only have 2 lobes. So adventitious breath sound. So these are sound that when we auscultate on the patient using the stethoscope, we often hear this sound in patients that have COPD or pneumonia, fluid in the lung. So these are the sound that we can or expected to hear. And these are adventitious, meaning like bad, adverse. So it's not a good sound. Normal person who have healthy lungs will not have these sound. So crackles, when we hear crackles in the lungs, especially lower lobe of the lungs, it means that the lung possibly has collapsed or there are fluid in the lungs. So why is fluid in the lungs bad? So fluid in the lungs, to be exact, is fluid in the alveoli sac. So like I said earlier, these alveoli sac have to be open and it had to be open and recoil. So when it's open, we inhale air in and it can get the air. But if there's fluid in the sac, there's not enough space for the air to fill in, and there will be a barrier between the air and the tissue to get the oxygen, because the fluid is separating between the air and the capillaries. Therefore, if we have fluid in the lungs, even though the patient can inhale air, but they don't actually exchange the gas, don't actually exchange the oxygen and the carbon dioxide because of the fluid. Hello, I'm sorry about that. I think there's something wrong with the connection. Can you guys hear me? I was cut off. Okay. Let me share this again. Okay, it's still sharing. I wasn't sure where did I stop. I stopped at the crackle and fluids, correct? You were saying the fluid in the alveoli sac. Yes, thank you so much. Okay, let me play from current slide. Okay, so whenever hear the terms crackles, or you guys look at the term crackles in the exam, immediately think that there is fluid in the alveoli sac. Diminished meaning we don't hear much sound at all, and this oftenly caused by fluid in the sac as well, pneumonia fluid, and it doesn't allow air to pass through, so that's why the lung sound doesn't have any sound, so it's diminished. Bronchi is kind of like crackle times 2. It means that it's more, when you guys hear the crackles and it's really heavy, that means that the patient had progressed into bronchi, and it's usually louder and chunkier, and it's associated with increased fluid volume. It means the fluid in the lungs, in the alveoli sac, has increased significantly. Wheezing is specifically for asthma. So whenever you guys see the terms wheezing, immediately know that it is asthma, or the test is referring to asthma. So it's important to remember that. Wheezing is just basically describing the bronchioles, because in asthma it's an inflammatory process. So the bronchiole will be inflamed and it's constrict. So there's no space in the bronchiole for the air to travel through. So that's why the patient often show sign of wheezing when they breathe. Stridor is really, really bad. Stridor is wheezing times like 100. It's a really, stridor is wheezing times 100. Wheezing is bad enough that the patient cannot barely breathe, but stridor is kind of completely obstructed, like the airway is obstructed. The patient could not get any air in. Okay, so wheezing is like stage 1, and then when the patient progressive stridor, especially in asthma patients, they can black out and die because of the airway obstruction. All right, so next we have respiratory patterns. So this is important to know these patterns as well. For example, the Kussmaul pattern, like we learned about it last week in diabetes. So Kussmaul is a very specific breathing pattern that usually or only occur in diabetes type 1 patient, especially patient who experience DKA, diabetic ketoacidosis. This is because of the metabolic acidosis built up in the body. The Kussmaul patient will have, the patient who in DK will have a very fruity acetone breath, but Kussmaul respiratory pattern is rapid and deep. So the patient will breathe very fast and breathe very deep, not shallow and deep. Not shallow and rapid, it's rapid and deep. So please remember that this is because the body trying to breathe rapidly so that they can expel the carbon dioxide outside of the body to reduce the acidic in the blood, because carbon dioxide is an acid. So in DKA, a patient the acid is so, the blood pH is so low, it's so acidic. So that's why this is a compensation of the respiratory system of the body doing this, so that it can lower, or it can make the pH more alkaline. Cheyne-Stokes is a near-death breathing pattern. It can be described as fast, then stop, then fast. Tachypnea is very fast breathing. Patient who breathe fast, what do you guys think? Patient who breathe fast often can easily experience respiratory alkalosis. Why? Because when we breathe fast, we expel more carbon dioxide out of our body. And like I said earlier, carbon dioxide is an acid. And when we lose too much acid, we'll go into a state of alkalosis. So that's why tachypnea, very fast breathing, can lead to respiratory alkalosis. Next, we have bradypnea. Usually patients who are bradypnea, meaning slow breathing, they are under influence of opioid. Because opioid analgesic, they are CNS depression, central nervous system depression. And when the central nervous system is depressed, the breathing pattern and the respiratory drive is also suppressed as well. So that's why patients who are in bradypnea, they often can easier experience respiratory acidosis, because when they don't breathe enough or they breathe too slow, the carbon dioxide will be built up in the body. And when we have too much carbon dioxide in the body, the acidic level goes higher, meaning the pH will go lower. The lower the pH is, the more acidic the blood, and carbon dioxide is acidic. So bradypnea, the patient at risk for respiratory acidosis. And then BIAT is just another term for irregular breathing. I don't think you guys need to know that. Next, we have respiratory diagnosis. So these are important to remember, especially, and it's a basic, it's foundation. So post-ox are these little cube machine that we put on device that we put on the finger of the patient, or sometimes it can be stick on the patient finger or earlobe or forehead. The reason for that is because sometimes on the finger, patient doesn't have good circulation. So that's why the nurses can put on the patient earlobe or forehead, where the oxygen is often higher concentrated there, to accurately measure the oxygen in the blood. So post-ox is in regular patient. The post-ox should be at least more than 90 for post-ox. If it's 90 or less than, we need to give them oxygen. For COPD's patient, at least more than 80 for post-ox. So usually 95 to 100% is normal. But for elderly patient or patient in the hospital, it should be at least more than 90%. If the patient post-ox is about 89, 88, they should be on oxygen, like 2 liters or something. And especially for COPD's patient, these patients are chronic, they live on low oxygen drive. So that's why if they are more than 80%, then they are okay. But if less than 80, that's when we concern. All right, ABG is arterial blood gas. This is very important. It will follow you guys up until the end of the semester. Usually, oftenly throughout the semester or in fundamental, they teach us how to use the tic-tac-toe method. I don't know if you guys remember that. So it's just basically, you guys have to know how to determine whether the patient is in respiratory or metabolic acidosis or alkalosis. So before we jump into that, we have to know the number first. These number have to know by heart. You guys have to remember this number. There's no way around it. pH is 7.35 to 7.45. So anything that less than 7.35 is considered acidic, and anything that more than 7.45 is considered alkalosis. Either state is not good for the body. The body is always trying to maintain in a homeostasis environment, which is between the range. If it's too acidic, it can damage the organ, damage the blood, as alkalosis. Carbon dioxide is 35 to 45. Again, I cannot stress this enough. Please remember that carbon dioxide is acidic. It's an acidic agent. So the more carbon dioxide we have, the more acidic it is inside our body. How do we get more carbon dioxide? When we breathe slower. When the patient breathes slower, the carbon dioxide is trapped, it builds up in the body. When the patient breathes fast, they will expel carbon dioxide faster, so they're more at risk for alkalosis. Next is HCO3. HCO3, also known as bicarbonate. It is the same thing. It is ranging from 22 to 26. So bicarbonate is HCO3 is completely opposite with carbon dioxide, because HCO3, they are known as a buffer. So the higher the buffer, the the higher the buffer, the more alkali the blood is, because these buffer will buffer these acidic agent and make the blood more alkaline. So if we have a low level of HCO3, it means that the body is in acidic state, and higher level of HCO3, this is considered alkalosis state. What secrete HCO3? Kidney. The renal system is what secrete bicarbonate. So if we have a bad kidney or a bad renal system, usually it will affect the bicarbonate and the body will be in a state of acidosis. And usually anything related to the kidney is metabolic. Okay. Next, we have respiratory acidosis, which is increased carbon dioxide and decreased pH. So complete sense, right? Carbon dioxide is relating to the breathing pattern, so it's relating to the respiratory, and acidosis is basically decreases the pH. Respiratory alkalosis is when the carbon dioxide is decreased and the pH is increased. Metabolic acidosis is decreased bicarbonate, HCO3. Remember, it's a buffer. So if we don't have enough buffer, of course, the blood will get more acidic. And where does the buffer being released? From the kidney. So that's why it's metabolic. And of course, acidosis is decreased pH, and metabolic alkalosis is increased bicarbonate and increased pH. All right. Next. So questions for ABGs. So I have some of these questions, so let's do them together. So for someone who in severe diarrhea, what do you guys think that they might experience? Acidic or alkalosis? Is it metabolic or respiratory? I just need to respond and then I can explain. Okay, metabolic, good start. Can you tell me whether it's alkalosis or metabolic alkalosis? Okay. Anybody else? So okay, so when we have severe diarrhea, we will lose a lot of our buffer, the bicarbonate. So that's why when we have severe diarrhea, it is actually causing the body to be more in a metabolic acidosis state instead of alkalosis. So for the first one, it is actually going to be severe diarrhea will lead to metabolic acidosis. Okay, so because when we have diarrhea, we lose a lot of our electrolytes through the loose stool, and this loose stool will also contain the bicarbonate, the buffer. So that's why when we lose a lot of buffer, it will lead to metabolic acidosis. Does that make sense for everyone? I know it's a little bit confusing, but these questions are so important to remember because I have test questions on these. Next, which one is severe vomiting? Metabolic alkalosis. That is absolutely correct. So the reason why when patient has severe vomiting, they in metabolic alkalosis is because when we vomit, we lose a lot of our stomach acid and stomach content. And you know, the stomach releases acid. And when we lose a lot of stomach acid and stomach contents, the pH will go up because the acid level is lower. So severe vomiting will lead to metabolic alkalosis. Metabolic alkalosis, okay? So it's different with severe diarrhea. Even though we both scenario, we lose this fluid, but the diarrhea, the stool, the flu, it contains a lot of our bicarbonate. So that's why it leads to acidosis. But when we vomit, we lose our acid stomach acid. So that's what leads to alkalosis. So please remember that. Next is NG tube suction. NG tube suction is the same concept with severe vomiting. When the patient on NG tube suction, the tube is inserted into the patient's stomach and they suction the content out. So of course, when we suction anything from the stomach, it causes we to lose the acid. So that's why patients who are on NG tube suction, they are at risk for metabolic alkalosis, because we lose acid, we lose stomach content. Next, which one is hypoventilation? Hypoventilation meaning they don't breathe fast enough. Respiratory acidosis, perfect, spot on. So when we don't breathe fast enough, we trap the carbon dioxide and it builds up in our blood and it causes acidosis. Which one is hyperventilation? Respiratory alkalosis, perfect. That's awesome. So when we breathe so fast, we lose our carbon dioxide at a faster rate. So we're more at risk for respiratory alkalosis. And then tricky one is, which one is severe dehydration? So for severe dehydration, so let's think about this. So whenever a patient is in severe dehydration, they don't have enough fluid circulating the body, so that the blood volume will also decreases as well. So when someone in a dehydrated state, the blood does not perfuse the kidney enough, and the kidney is producing urine. The kidney is able to produce urine when we have enough blood, when we have enough fluid go through the kidney. The kidney filters the blood in order to make urine. If the blood volume is so low because we dehydrated, we don't have enough volume in our body, therefore it will causes metabolic. Well, actually it causes metabolic, yes, it actually causes metabolic acidosis because the kidney doesn't have enough filter or blood perfusing the kidney, so it does not produce the bicarbonate, it does not produce the HCO3 like it should, and we don't have enough the HCO3, we are going to be in a metabolic acidosis state. Okay. So severe dehydration will affect the kidney. The kidney cannot produce bicarbonate, and bicarbonate is a buffer. So when we don't have enough buffer, we have the acidic level is higher. So severe dehydration will lead to metabolic acidosis. Good job, guys. All right. Next, we have respiratory diagnosis. So there are different diagnosis tests, and these are important to remember at all. Remember, so we need to know, so we can know what these tests used for. So basically, the first set is pulmonary function test. So these tests is only for patients who show poor respiration. I'm sorry, guys. I'm so mad at the Wi-Fi right now. Let me share this again. You guys can hear me now still? Yes. Okay. Thank you. I apologize about that. So the first test is the pulmonary function test. This is only for patients begin to show poor respiration function of asthma. So it tests the power of the lungs. So usually this test is prescribed for patients who are asthmatic, and only when they have adverse symptoms or they have a very poor respiration function. Next, we have bronchoscopy, thoracoscopy. So this test is used to visualize the patient lungs. For this test, the patient must be NPO for at least 48 hours prior to the procedures. Uh, it is so it is really important that the patient is NPO prior for this procedure. It may be used to obtain biopsy, remove object, assess airway damage, and stage cancer. So this is the indication of these tests. So lidocaine is sprayed into the back of the throat to numb the gag reflex. So basically the doctor will put this like visualized tube into the patient mouth and into the patient trachea. So that's why they need to spray the lidocaine in their throat so that they can numb the gag reflex of the patient. So when the patient come back, they are at risk for aspiration numb because their gag reflex was numb. So we don't give them any water, and we must check their gag reflex and cup reflex before we administering food. So that is really important to remember. So for example, if you guys have a question on the test regarding the patient return from a bronchoscopy procedure, what do we do? The first thing that we need to do is the priority thing is to check the gag reflex before we can administering food or water. Okay. And that is also the reason why they need to be NPO, because if they eat too much before the procedure and their gag reflex is numb, or there is issues where they can aspirate, the procedure may cause vomiting and they can aspirate because of the food that they ate. Aspirate basically means that the food from the stomach or the food that they eat enter the trachea instead of entering the esophagus. And if the food is entering the trachea, it can cause airway obstruction, and that what it means, aspirate. Next, we have another test is thoracentesis. So thoracentesis is basically the withdrawal fluid from the lung for biopsies. To prepare, the patient need to be put in tripod position. So please remember this. If the question asks what is the position for thoracentesis, it is tripod position. A tripod position is a position where the patient will sit up and both of their hand will be both the hand and their body will lean to a table and forward so that they can expose the lower region of their back, the lumbar region, so that the doctor can withdraw the fluid from the thoracic cavity. So the potential complication is pneumothorax. Pneumothorax is basically means that when the doctor poke the patient with the tube to get the lung fluid out, it can penetrate the lung tissues and can cause a hole. That's what it means by pneumothorax, or lung collapse, or diminished lung sound, or tachypnea, trachea deviation if lung collapse. So usually the trachea, it will deviate it, meaning it will not be on midline anymore because one of the side of the lung is collapsed. And when the side of the lung is collapsed, the trachea will deviate it to the good side, okay? So when it's deviated to the left side, meaning that the right side was collapsed. Next, we have sputum test. So any infection, pneumonia, or any issues with infection, we do the sputum test to test for the specific strain of bacteria so that we can give the proper antibiotic to treat for that specific bacteria strain so that we can kill it. And we always do sputum test, or we prefer to do the sputum test in the morning. The reason why we do it in the morning is because after a full night of sleeping, the patient usually have the most secretion in their nose or in their sputum or in their mouth. That is when the sputum was built up through the whole night. So that's what we do it in the morning. And that would usually be asked to, sometimes Professor Lanessa just asked in the test that what time do we usually do the sputum test? Next is pneumonia. So pneumonia is a fancy term for infection in the lungs. So infection is basically an an entry of any bacteria into our internal organs. That means infections. So because whenever anything bacteria or viruses entering our body will elicit the inflammatory response. And when the inflammatory response, the capillary wall will become leaky, and the fluid inside the capillary wall will shift from the capillary to the interstitial space, then the alveoli. Interstitial space is the space between the cells. And then it will lead to the alveoli. And you guys, like I said earlier, alveoli are these tiny sacs. It is where the gas exchange occur. And whenever there's fluid that is leaking or get into the alveoli, we don't have enough space for the air to enter the body or to exchange gas. So the alveoli over time will be filled with fluid if the patient is in pneumonia. It will cause VQ, something called VQ mismatch. So VQ mismatch is basically means poorly oxygenated blood returns to the heart, leads to arterial hypoxia. Okay, so again, pneumonia is basically an infection to the lungs caused by bacteria or viruses. It leads these bacteria causes the body to elicits the inflammatory response, leads to alveolar edema and exudate formation. Exudate are these white blood cells, pus that will form when the inflammatory response is elicited. And then the alveoli and respiratory bronchioles fill with serous exudate, blood cells, bacteria, and fibrins. And this will lead to a consolidation of the lung tissues. So the word consolidation is just basically means that when we look at the X-ray, when we take a picture for someone who have pneumonia, their lungs will be white and it's consolidated. It's filled with fluid and pus and all this stuff. Continue for pneumonia. So the sign that we see that in a patient who have pneumonia is the lung size will be diminished, fever, they will coughing green and yellow mucus, the white blood cells count will increase. However, it doesn't tell us that they have a lung infections even chest X-ray. A positive sputum culture will confirm the pneumonia. The culture is done in the morning for more buildup. So it is important for us to remember that X-ray is to visualize how the situation of the patient lungs, but it is not a confirmatory test that can tell us the patient have pneumonia. A confirmatory test is a positive sputum culture. Okay, and we always done the culture in the morning for more buildup. And so here's the thing about the culture. So a patient coming in, they are suspected of having pneumonia. We always do the culture first before we give them any kind of antibiotic. So we do the culture, we give them a broad spectrum antibiotic. Broad spectrum is not a specific antibiotic. It's just a broad spectrum. It doesn't target a specific strain of any bacteria. So we do a sputum culture. Then while waiting for the result of the sputum culture, we give them a broad spectrum antibiotic. After we have the culture result come back, we know the exact bacteria. Then we give them a specific antibiotic for that bacteria. So that is how it usually be done in the hospital. So how do we prevent pneumonia in patients? We have to teach the patient to use incentive spirometer. It is this machine, it's device that the patient can breathe in and to expand their lungs. We ask them to do a lot of breathing exercise, and antibiotic is a priority in pneumonia because it's at the end of the day, pneumonia is an infection. It's caused by bacteria. So we have to eliminate the cause. We have to kill the bacteria so that the patient can get better. Turn, cough, deep breath. TCDB is turn, cough, deep breath. So yeah, we need to turn the patient not only to prevent pressure ulcers, but also to help mobilize the secretion in the lungs so that the patient can be free of pneumonia. And then pursed lips. Pursed lip is basically just breathe in and breathe out, opening your lips. And chest physiotherapy is where you guys have your hands cuffed like this and kind of cuff the patient back so that the secretion, the mucus stick on the patient lung can all drop down, and then they can cuff those secretion and mucus out of the mouth. So the treatment for pneumonia is, of course, we have to do sputum culture, and then we do the antibiotic. We start with a broad spectrum antibiotic while we're waiting for the culture. Always continue to give antibiotic until sputum culture come back. So there's a thing with antibiotics. So whenever we are prescribed antibiotic, for example, for 10 days, the patient must take the whole antibiotic course for 10 days. They cannot, even though they get better after 5 days, they cannot stop the antibiotic. They have to take the full course, because if they stop in the middle and they don't finish their full course of antibiotic, it can lead to bacterial resistant, and the antibiotic will not be as effectively for them in the future anymore. So nurses always have to teach the patient to take the whole course of antibiotic, okay? Even if they get better. So always have to hydrate the patient. The more hydration, the thinner the mucus, and the thinner the mucus, the easier for them to expectorate, to cough those mucus out of the mouth. And then administer mucolytic and bronchodilator. Okay, these are just medication that help to dilate the bronchioles, and mucolytic is to thin the mucus. Next, we have something called atelectasis. So earlier I mentioned this. Atelectasis is basically collapse of the alveoli. The alveoli cannot expand or recoil as effectively, so it leads to ineffective gas exchange. These patients are common bedridden. Bedridden is basically just lie on the bed. They can't move so much. They cannot ambulate. They cannot stand up or walking. So that means bedridden. And because they lie on the bed the whole day, this mucus and this their lung is not exercised. They're not breathing well. It can lead to collapse of the alveoli. Or post-op patients. Post-op patients usually under anesthesia still, or they are too in so much pain that they don't even want to walk out of the bed. So they are at higher risk for atelectasis. Causes lower oxygen supply to the tissues. Assessment: these patients will have dyspnea. Dyspnea is difficulty breathing. Leukocytosis basically means they have a high white blood count. Sputum production, crackle in the lungs, decreased blood, what is BS? Tachycardia, anxiety, pleural pain, hypoxemia. I'm not sure what is BS mean. Probably can just ignore that. But usually they will have tachycardia, anxiety, pleural pain, and hypoxemia. Yes, decreased breath sound. Thank you so much. Yes, decreased BS meaning decreased breath sound. And they'll have tachycardia, anxiety, pleural pain, and hypoxemia. Pleural is the chest area, so yeah. Atelectasis can progress to pneumonia if the fluid sits in the lungs too long. And whenever fluid sits in the lung, it's become a good place for bacteria to grow. Treatment: we teach them to do incentive spirometer, turn cough deep breath, early ambulations, fluid, and preventions is key. So the earlier they can ambulate, they can start walking around the waiting hall or around the bed, the better the lungs get, and the less risk they have in developing atelectasis. Okay, next we have asthma. So a lot of people are born with asthma or have an issue with asthma. So basically, asthma is reversible airflow obstruction. So reversible is a very important keyword here to remember. It is reversible, meaning it can be converted into the normal stage. It is a reversible airflow obstruction caused by diffuse airway inflammation and constriction when exposed to irritants. What is IS on the atelectasis side? No problem. The IS on the atelectasis slide is called the incentive spirometer. It is a little device that the patient are often given so that they can breathe in. No problem. So asthma, it's caused by the airway inflammation and constriction when exposed to irritants. Obstruction in the airway due to narrowing of the bronchioles. So because the bronchioles is narrowing, the patient cannot get the air into the alveoli. So that's why they have wheezing, or in a very severe case, stridor. It caused by environmental factors or exercise-induced asthma. So when you don't normally exercise and then you go so hard, you do all this HIIT workout, and then you have a background of asthmatic episodes, and it can trigger asthma as well. It triggered immune response, and as a result, the airway will get inflamed, the bronchiole will be constricted, no air can get in or out. Basically, it is an obstruction in the airway due to constriction of the bronchioles, triggers by allergens, exercise, high stress, foods, or medication. Food can be peanut, allergens can be like dust, pollen, or cat, dog hair, or even bee sting. So yeah. Early asthma, so these are, we have to know both early sign and late sign. So early sign of asthma is cough, wheezing. This tells that the bronchioles are narrowing. Difficulty breathing, chest tight, anxiety, and patient sit up. Late sign is the wheezing turns into stridor, then absent of the wheezing, breath sounds become very bad, wheezing turns to no breath sounds, and it causes close up even more. Number one priority is always having rescue inhaler, albuterol, and never go without it. Okay, so albuterol is a short-acting medication that can help the patient dilate the bronchioles. Okay, so the number one priority for asthma is always have a rescue inhaler in possession, so that they can breathe, they can get a buff and dilating their bronchioles. Next, we have airway obstruction. So airway obstruction is a medical emergency. The brain can be damaged or death within 3 to 5 minutes out without oxygen. This can be caused by asthma or due to an anaphylactic hypersensitivity reactions. Anaphylactic hypersensitivity reaction is just basically there's a foreign, like peanut or a bee sting that entered the body, and the body recognizes it as a foreign object, a dangerous object, and it causes all of release of histamine and all of these inflammatory response to that, and it causes the patient to the bronchioles to constrict, similarly to asthma. So that's why it causes airway obstruction. If patient has an airway obstruction due to some type of allergic anaphylactic, we give them steroids, which will help that immune response. If the airway is completely occluded, we give them something called tracheostomy. It is an incision made through the airway to bypass the airway occlusion to help oxygenate the patients. So I think we go over tracheostomy in fundamental, but it's so important to know about trach and how to suction the patient and all of the information about it. So that's why I prepared this slide. So tracheostomy is is a procedure. Again, it's facilitate the secretion of the removal. It's making an incision on the patient airway so that because the airway is blocked, so we're gonna make the incision through the airway, and we use a tool to secrete all of the mucus inside the patient airway of the thing that obstructing the airway. We assess the needs for suctioning hourly, includes coughing, coarse crackles, wheezes, moist cough, and agitation. So know this. This is what I have in my note before and after my exam. So I think that these are important to know about trach, okay? So for trach, sterile dressing is done at least 12 hours, Q12 hours, meaning 2 times a day. Provide pre-oxygen at least 30 seconds. This means that before we suction the patient, we have to pre-oxygenate them for at least 30 seconds, and then we suction. When we suction, we insert the tube into the trachea right here around their throat until the patient cough. When the patient cough, that when we know that we have inserted far enough. So we have to immediately stop the suction if the patient become bradycardic, meaning the heart rate drop, or hypotensive, the blood pressure drop, dysrhythmia, or the SpO2 less than 90%. So this bring up the post-ox. So before we do the tracheostomy suction, we have to put the post-ox on the patient finger. And when we suction the patient, we have to continuously monitor that post-ox. And if the post-ox is less than 90%, we have to stop the suction immediately. Then we have to wait at least 30 seconds to suction again, and must hyperoxygenate it for at least 30 seconds between suction. And we only allow 3 passes of suction at a time. If not all clear out, we let the patient rest, and then we come back and suction the patient more. Always keep a replacement of the tube, equal or smaller size at the bedside, and the set that usually be kept next to the patient bedside when they have a trach is an ambu bag, a replacement trach, and suction. When is it appropriate to change dressing? When it gets soil, get wet, or colored. When dressing you use to cover, what dressing you use to cover, we have to use a dry dressing, because remember, whenever there's moisture, there are easier for bacteria to grow, and it can cause skin breakdown. Suctioning is a sterile procedure because anything else enter the trachea have to be sterile. If it's not sterile, even the smallest bacteria, it can cause pneumonia in the lung. The trachea and the esophagus is different because when we eat, there's bacteria in the food, there's bacteria in our hand, we bite our nail, the bacteria can enter our body. However, it's entered through the esophagus and there's acid in the stomach. It kills those bacteria. But the trachea, it leads to the bronchial and the lungs. There's no acid in the lungs. So that's why if we have bacteria or any foreign viruses entering our trachea, it can cause pneumonia, or it can have a lot of issues with the alveoli and the lungs. So remember, suctioning is a sterile procedure. Sterile is different with aseptic. Sterile is like no bacteria. Maximum is only 3 suction per suctioning, no more, because it can cause complications. When suctioning the client, how do we know how far we need to go down? Again, when the patient start coughing. When suctioning the patient, the biggest complication is not getting enough oxygen. In order to avoid this, before suction, we hyperoxygenate them and then also oxygen them as soon as we finished. Okay, and when we say as soon as we finished, is as soon as we finish per suctioning. For example, we're gonna suction them 3 times. So we pre-oxygenate them, suction, and then we oxygenate them and then suction. And the total amount of each time we suction them is only about 10 seconds or less, okay? All right, next we have tuberculosis. Tuberculosis is huge. Tuberculosis is very important to remember, very important to know, and it's actually all around us. We have to, when we go to school, nursing school, we have to do a tuberculosis test. So, so this is why it's important for us to know what is being done on our body. So tuberculosis is another type of infection in the lung. However, there's a specific strain of bacteria that causes tuberculosis, and this strain is called acid-fast bacilli. Acid-fast bacilli is very resistant to treatment unless it is identified. Bacteria goes into the lung and tear it up. The patient will show symptom of fatigue, malaise, night sweat. I have 2 stars here, so definitely remember this classic sign, night sweat. They have chronic productive cough and hemoptysis. Hemoptysis is cough of blood, and this is an advanced stage. I spelled it wrong, but it's hemoptysis, yeah. It's basically coughing up blood. Pleuritic, meaning chest pain when breathing, and low-grade temperature. So for example, a patient coming to the ER, you an ER nurse, and then the patient start coughing up blood, and they mention that they have night sweat, the nurse should wear a mask and start isolation immediately. All right, tuberculosis, a positive finding of tuberculosis is that we put a TP, like the injection TP in our arm that you guys did. It will cause a little reaction. It caused this to bulge up a little bit, it swell a little bit, and it have redness will occur immediately after they put it on. So if it stays swelling and big after 48 to 72 hours, it means that you may have exposed to TB. It is really important to remember that a positive indication of tuberculosis skin testing is only means that you may have been exposed. It does not mean that you have TB. It just means that you may have been exposed. This test is only telling you that you may have exposed to TB. So basically the area in duration is measured. You guys have to know this and remember this. It will be on the exam. If it's more than 15 milliliters for the general public without risk factor, it means that they may have been exposed to TB. So if the swelling is bigger than 15 milliliters, that is for the general public, the one who doesn't have any risk factors. Next, we have more than 10 milliliter. More than 10 milliliter is for resident of long-term healthcare facility. Long-term healthcare facility, IV drug abuser, and healthcare worker. We are healthcare worker. We are nursing student or future nurses. So if we do a TB test and it is bigger than 10 milliliter, it means that we may have been exposed to someone who have TB. So if it's 12 milliliter and we are a nursing student or a nurse, that means that we may have been exposed to TB. But if it's 12 milliliter for general public, someone who without risk factor, for example, a teacher, and it's 12 milliliter, that is not a positive test. That is a negative test. They have not been exposed to TB. 12 milliliter is only for healthcare worker. Okay, so if it's 9 milliliter and it's healthcare worker, it does not mean that they have been exposed. You guys know what I mean? It's a little confusing, but yeah. So lastly, it's bigger than 5 milliliter. So if the swelling is bigger than 5 milliliter, for the HIV positive or recent contact with active tuberculosis, it means that this patient may have been exposed to TB. Okay, so it's all about the size of the swelling. The bigger the size, the worse the case. So next step is TB test, X-ray to see what's going on in the lung. This is still not a confirmatory for TB. So when we do a TB skin test, after 72 hours, we come back, they take a look at the swelling. If the swelling indicate a positive finding, then they will send us to do a chest X-ray. And then in order to confirm that we have TB, tuberculosis, we do a sputum test. So this sputum test will test for acid-fast bacilli. If the test comes back positive, meaning that there are present of acid-fast bacilli in our sputum, it means that we have tuberculosis. So tuberculosis patient is often put in isolation in a negative pressure room until we have 3 acid-fast bacilli negative tests and still stay on medication 6 to 12 months, even after 3 times negative result of acid-fast bacilli. So this basically means that a tuberculosis patient, they have to be in isolation. And then they will have to be given medication, and they have to take TB medication for a long period of time. And throughout the time that they in the hospital taking this medication, they will be regularly test their sputum. We regularly obtain the culture from the sputum. And then if they have 3 consecutive acid-fast bacilli negative sputum test, they can be released outside the hospital. However, even though they are being released outside the hospital and they have 3 negative tests, they still have to be taking TB medication up to 6 to 12 months. All right. Are you guys doing okay? Do you guys want to go to have a break, or you guys want to go through? How many chapters are we in? Today we're only covering respiration. All right, awesome. Then we go ahead and continue. So right now we are going to discuss about COPD. COPD is destruction from the alveoli collapse, and it is not reversible. So earlier I mentioned about asthma, and I said, please remember the keyword reversible. Here for COPD, please remember the keyword not reversible. Okay, so if on the test they mention something about not reversible, it is COPD. And if it is reversible, it is asthma. So COPD is a combination of emphysema and chronic bronchitis. So what is emphysema means? Emphysema means the loss of elasticity of the alveoli. That means that the alveoli is so damaged that it cannot recoil and it cannot like go up and go smaller. It cannot recoil. The elasticity is not there anymore. So whenever the elasticity of the alveoli is lost, the gas exchange in the body is bad. So they will have ineffective gas exchange. Chronic bronchitis is rigidity of the airway due to chronic inflammation and scarring. Rigidity meaning not flexible. The bronchioles are not constrict or dilated as flexible as before anymore. It's very rigid, and when it's rigid, it's hard for the patient to breathe or inhale the air in. So the patho of COPD is basically increased mucus producing cells. Chronic inflammation, the bronchiole is narrowed, is clogged with mucus, structural changes in the lungs. So basically COPD is all about gas exchange. The gas exchange doesn't work correctly, then it leads to trapped carbon dioxide, and the body compensates by slow down the breathing. Oxygen toxicity is a huge concept with COPD because these patients when we give them too much oxygen, it is actually not good for them, even though they need it. But when we give them too much oxygen, it can lead the body to it can lead to that they don't breathe anymore. So the drive of the body to breathe is low oxygen. For COPD, we cannot give them more than 4 liter. That's basically what it means. We cannot give the COPD patient any more than 4 liter of oxygen. So please remember that if we give more than 4 liter of oxygen, it can lead to something called oxygen toxicity in COPD's patient. Priority nursing intervention in COPD is to fix the alveoli, to opening up the alveoli. Sign and symptom of COPD include dyspnea, chronic cough, barrel chest. Barrel chest is the chest is when you look at the side profile of the patient, you see that the chest and the back is really big. The breath sound usually occur in COPD is called rhonchi. It is described as low pitch associated with fluid in the lower airway and narrowing. These COPD patients usually in tripod position. Earlier, remember, where they sit up and they have both of their hands and they lean forward. That is called tripod position. Because this patient is hungry for air, they uses a lot of accessory muscle when they breathe. They will have clubbing of the nails, meaning that the nails will be very like protruding up. It's clubbing. The nails often is thin. They will have prolonged expiratory, diminished breath sounds, and prolonged expiration, and of course, rhonchi and wheezes. So the checklist for COPD is to prevent and control acute attacks. So we have to teach the patient proper use of inhaler in order to dilate the alveoli. We have to teach them the pursed lip exhalation. So to force air to open the alveoli, as well as using inseminative spirometer. IS is inseminative spirometer. Pursed lip exhalation is just whenever they breathe out, the lips kind of pursed, like open up a little bit. And then we have tripod position to help breathe easier, abdominal breathing, adequate fluid intake to thin mucus. We have to teach them the cough technique, including deep breath, forceful cough, help increase interthoracic range and open up alveoli, and huff cough. Huff cough is basically, they say the word huff when they cough. It will facilitate the removal of more secretion when they say that. Avoid trigger, give more fluid. COPD patient should have annual flu shot, and they need to have pneumococcal pneumonia vaccine, and they have to quit smoking. All right, that is it for today respiration guide. So how are you guys feeling so far? Do you guys me to go over briefly some of the medication so that you can know a little bit? I know I was in the same shoes. Yeah. Okay, let's take a quick break, a 3-minute break, and then we come back for the med quiz. But yes, let me answer this question real quick. Can you explain how the med quiz are organized? So the med quiz are organized is basically, I think you guys have the lecture first, and then she's gonna have the quiz for you guys take right there through responders lockdown browser. And then I think it's about 10-12 questions, and it's basically asked mostly the significant thing about the medications. So for this week, I think the medication that you guys are going to go over is the perioperative medication, the diabetes medication, and then the respiration medication. Is it multiple choice? I'm not, it is multiple choice. It's always multiple choice. She never asks you to fill out or remember the name, exact word of any medications. It is multiple choice. It may be select or apply for some questions. But yeah, the most important medication that I think you guys need to know is definitely diabetes, because the respiration medication is not difficult, and the perioperative is not difficult either. So yeah, we can take a look after the break, and then so you guys can feel a little bit better. Okay, so let's have a break. We will come back at 3:13. Let's have 3:15. Let's have 5-minute break. Okay, I'll see you guys right back at 3:15. All right, let's me resume and let's go ahead and quickly look over some medications so that we have a better understanding. So the MedSurg will be separated. Yeah, you do it individually. You don't do it in groups, and it is not open booked. You should give you a little bit of time, and then you do the test there. It is not open book. So like I said earlier, the three main things that you guys need to know is the perioperative medications, diabetes medication, and the respiratory medication that you guys are going to go over tomorrow. She will hit very heavily on the diabetes medication, but also don't forget about the perioperative as well. So from what I remember from perioperative, please remember the G and the E's. So any vitamins or any medication that have the G's and the E's, if the patient take, it have to be stopped 72 hours. It have to be stopped prior to the surgery. Let me pull up my note. Oops, it's not this one. It's medication sheet. Please give me 1 second. Can you guys see the screen that I'm sharing right now? Yes. Okay, so let's look at the perioperative first. So stop taking oral herbs 2 to 3 weeks before any surgery is the very important thing. So we need to know that. Anticoagulant blood thinner must be off 72 hours to 1 week prior to surgery. So these are the anticoagulant. This was in your PowerPoint last week too. So the G's and the E's, vitamin E's can cause excessive bleeding during surgery. So if there's a question about the G and the E's and the patient just recently take the G and the E's herbs or take any NSAIDs or blood thinner within the time frame, like 2 hours or 1 day before the surgery, you guys have to tell the surgeon, to notify the surgeon in order to withhold the surgery so that they not be at risk for bleeding when we do the surgery. And for steroids, we always need to know that we cannot abruptly stop steroid because it can cause kidney failure because the steroid, it target the adrenal gland. The steroid can increase blood sugar, and its stress can also increase blood sugars. For these, you don't really need to know. Yeah, but no dantrolene and ketamine. So dantrolene is the antidote for malignant hyperthermia. Ketamine is again an anesthesia that must require a quiet environment during and getting out the surgery to administer because of the potential hallucination side effects. So it is crucial that we remember the ketamine, not only during it, but also when they're getting out of surgery, who receive ketamine. The environment has to be very quiet, otherwise the patient can get hallucination. All right, week 2, diabetic drug, insulin, and oral diabetic. So it is really important that we know that the oral antibiotic is only given for the type 2 diabetic patient. Patient in type 1 diabetes, we don't give oral medication, we only give them insulin. Okay, so anti-diabetic drug, we have biguanide. So the important thing is you guys have to remember, what is it called? It's called metformin glucophage. What does it do? It reduces glucose production of the liver. And then the side effect is may cause weight loss, nausea and vomiting, and it's very hard on the kidney and the liver. So kind of know like the look at the med sheet or like the information that she give you guys and like write down everything and kind of remember the big thing about it. So we have to hold this medication for at least 48 hours and after the diagnostic test with contrast or any procedure require MPO. The reason why it has to be whole 48 hours before the diagnostic test with contrast is because metformin is very hard on the kidney. And whenever there's contrast, it's a dye, it can cause issue with the kidney as well. So if two things both cause issue with the kidney, it can blow up the kidney. So that's why we have to hold this medication before the patient going through the diagnostic test with contrast. And of course, do not use alcohol. Honestly, with any medication, do not use alcohol with it. It is contraindicated with renal and liver patient. So of course, because this drug is very hard on the kidney and the liver. The second is the sulfonylureas. You guys have to know briefly about it, but don't get stuck too much on it. Yeah. But know the class name for sure, like the sulfonylureas, know biguanide, know metformin. So this drug increases insulin production from the pancreas because it's work in the pancreas. The major side effect is hypoglycemia and causes weight gain. So why does it cause weight gain? Because it's due to retaining water, and it also increases insulin production. So before the patient when they don't have insulin, they cannot utilize the glucose that they ingest inside their body. They cannot, so that's why they lost his weight. But when we give them this medication, it increases the insulin production. This insulin they can take up all the glucose that the patient eat. So that's why it can lead to weight gain. So weight gain is a big thing for sulfonylureas, and know that this medication increases insulin production from the pancreas. We need to take this medication before a meal, 30 minutes, and look out for hypoglycemia sign, because again, it causes an increase in insulin production. And if this medication given and the patient don't eat, there will be too much insulin in the body and it can lead to hypoglycemia. Next, we have meglitinide. So this medication also increases the insulin production from the pancreas. However, it's had a rapid onset. So it decreases the risk of hypoglycemia. So because it increases insulin production, that's why it causes weight gain. You guys see the correlation here. Must take 30 minutes to the first bite of food to mimic the normal response of eating. Because we take this medication, it increases insulin, so we have to eat food. So if the patient skip a meal, we do not give the med. If the patient already starting to eat, we still give the med, because that's good, because we want them to eat. Next is alpha glucosidase inhibitors. So basically, this medication is a starch blocker. It slows down the absorption of carbohydrate in small intestine. It works in the small intestine and it inhibits glucose absorption in the GI tract. Take with med first bite of each meal. So it can cause hypoglycemia when given without food. So yeah. And then lastly is the thiazolidinediones. This medication is also known as insulin sensitizer. This is most effective in those with insulin resistant. So this means that the patient produce enough insulin, but the insulin is not working effectively. It's very resistant. So it improves the insulin sensitivity, transport, utilization, and target tissues. Side effect is fluid retention, elevated LOD, hepatotoxicity. So it's bad on the liver as well. Okay, so this is really important to remember as well. She will ask you guys a question regarding rapid acting, short acting, and intermediate and long acting. So like I said, knows all of these names, know the logs, know the onset, peak, duration, and these drugs must have an onset 15 minutes. So it should be injected within 15 minutes of meal time. So this is crucial to remember. So please remember that. And then the short acting insulin, this is regular. So it's Humulin R, Novolin R. Of course, remember these. And then it is really important that we know that these drugs have an onset of 30 minutes to 60 minutes. So we know that we have to inject them 30 to 45 minutes before the meal. Are you gonna? No, I'm not gonna upload this document. Yeah, I just share with you guys. I don't know if I'm supposed to do this, but you know, we all want to be success, and as long as you guys study hard, then what's the matter? But I don't think I'm able to post this document. I'm sorry. But you know, feel free to take a picture. Intermediate NPH, Humulin N, Novolin N. So note this onset. So intermediate medication, insulin can be mixed with short and rapid acting insulin. So that is important to remember. It is cloudy. So it's much agitated, meaning move the insulin in the circulation motions to mix. So this is in funds that we learn. We learn about air to cloudy, air to clear, draw up clear, draw up cloudy. The only cloudy medication is the intermediate, and it can be mixed with the short and the rapid, okay? And then finally is long acting. So the long acting insulin, we never mix or dilute with any other insulin, okay? We never mix any else on the long acting insulin with any others in solution. The only thing that we can mix together is intermediate, short, and rapid. And the only insulin that is cloudy is the intermediate. So know the onset, know the peak, know the duration, and know the meal time according to the time of given the insulin. All right, so week 3, TB medication. So the really important thing that I think you guys need to remember about TB is it is very liver, hard on the liver. It can cause liver toxicity. So of course, don't drink alcohol, and we have to monitor liver function tests and kidney, including BUN and creatinine. And TB, tuberculosis, is airborne precautions. So when it's airborne precaution, we have to put them in negative pressure room and wear N95. Okay, so regarding TB medication, I think know this, no isoniazid, it will lead to hepatitis, meaning that it will be hard on the liver. Rifampin, it not only hard on the liver, but it also causes the body fluid to turn orange. This is a normal expected side effect. So if the patient freak out, we just need to tell them that this is a normal expected side effect, and we do not stop the medication just because the body fluid turns orange. And yeah, so Professor Lanasa will go over with you guys the respiration medication tomorrow. The most important thing that she's gonna ask you guys, or I think that she's gonna ask, is about the liver toxicity, how the TB medication is really bad for the liver. and asthma medication. So she will go over asthma medication with you guys as well. But earlier I mentioned about albuterol. So albuterol is the first medication to give for someone who have an acute attack of asthma. So when they have asthma right there and then, we give them albuterol, which is the inhaler, so that they can help the acute attacks and fix it fast. Okay, so that pretty much it. She will go over with you guys' respiration. I don't want you to like stress you guys over it. It's not gonna be she's not going to stress it on the respiratory medication too much, because you guys are going to have a med quiz tomorrow. But please learn the diabetic medication, because that's where she hit most. And for the preoperative med, just know the ketamine, the dantrolene, and know like the appropriate time of when to stop the blood thinner, anticoagulants, and NSAIDs. Okay. How do you guys feel? Does it help? Do you guys feel it was helpful? I hope it's helpful. Yes, don't stress about it too much, but of course, trying to make the best grade that you guys can. Just study. There's no way around it. Just study. Okay. Thank you everyone so much for joining today. I'll go ahead and end the session. I will post this on YouTube, and hopefully you guys can, if you guys watch or share with you guys, share with others. And you're very welcome. Thank you all. Thank you so much.